Now, we are very privileged tonight to partner once again with High ASI, as of course we continue to ensure that we occupational health physicians are updated on the current management of cases, as we often see this in our workplaces. And what's special about this activity for tonight is that we have not only one, not even just two, but we have three topics that we will be discussing tonight, and this will be discussed, of course, by our colleagues who are experts on gastroenterology, rehabilitation medicine, and psychiatry. So having said all that, we know that we will indeed have a busy night. And so without further ado, I would like to introduce to you our first speaker. Okay, so our first speaker is the training officer of the Division of Gastroenterology of the Department of Medicine, UPPGH. He is a clinical associate professor, Division of Gastroenterology, Department of Medicine, UPPGH, and currently the Vice President of the Philippine Society of Digestive Endoscopy. Ladies and gentlemen, let us all welcome the training officer of the Division of Gastroenterology of the Department of Medicine, UPPGH. It's none other than Dr. Ruther Maralit. Good evening, Dr. Ruther. You may have the floor now. Thank you.
Good evening, everyone. Dr. Rosel, first and foremost, I would like to thank the Philippine College of Occupational Medicine and High SI for inviting me to give this talk. Now, I have a very interesting topic tonight because it would be one of the more, if not one of the most common causes of consultation for us gastroenterologists. And I would like to share my experience with handling patients with functional constipation. And I know in your line of work, you also encounter these kinds of patients. So again, thank you very much for giving me this opportunity. So this would be the outline of my talk. First, I will give you a brief overview of what constipation is and what is chronic constipation. Then we will have case studies of patients with constipation. And I will delve into the ileal bile acid inhibitors, which is ilovixibat, which is now a more effective treatment for chronic constipation. I will also discuss about some of the lifestyle modifications that we can use to aid in the treatment of this disease or this condition. So first, let's first discuss the pathophysiology of functional bowel disorders. When you say functional bowel disorders, there's a lot, from dyspepsia to diarrhea to constipation. So all of these are considered functional bowel disorders. These are disorders of the disturbed gut-brain interactions, including different predisposing factors and abnormalities at different sites along the gut-brain axis. So ito po, if you look at the slide, you would see that there is a function of the microbiota, there is genetic predisposition to some of this condition, there are even psychosocial factors, the inflammatory response of the body, even the abnormal gastrointestinal motility, and the early exposure to certain environmental factors, and sometimes even visceral hypersensitivity can affect the overall functional bowel disorders that our patients will encounter. So the gut-brain axis is known to act up, especially for these kinds of conditions. So functional GI disorders or functional bowel disorders are highly prevalent worldwide, with the prevalence of about 40%. They are more common in women and relatively decreases with age. It accounts for about 12% of the workload in primary care settings and 30% of all GI OPD consultations. More than 2/3 of patients will have seen a doctor in the last 12 months. Some of them, you guys, and roughly 40% usually end up taking regular medications. So, functional GI disorders are often associated with chronic pain and some other functional syndromes like fibromyalgia, chronic fatigue syndrome. There can also be psychopathologic conditions such as anxiety and depression. In fact, during the time ng pandemic during the COVID pandemic, in the peak of it, we have seen increased patients complaining of chronic constipation because of increased anxiety. Although the patients who do have COVID infection initially during the first wave were actually presenting with diarrhea. So those who were really stressed because they were isolated and are not allowed to come out, they developed, some of them, functional constipation. So they really have very poor quality of life because sometimes they complain that these are worse than other chronic medical conditions. For example, some of them, they say that you can see this in those with patients with heart failure, those with rheumatoid arthritis, those with lupus erythematosus. So these functional GI disorders add up to the disease process that these other patients already have. Okay. So constipation. Ano po ba ang constipation? Constipation, on the other hand, is a condition. It's not a disease per se. No? It's a condition which you may have fewer than 3 bowel movements a week. So your stools may be hard, dry, or lumpy. And there are stools that are difficult or sometimes even painful to pass. And there's a feeling of incomplete defecation or incomplete evacuation. So, ano po yung disease? Constipation is a symptom. So, what's the disease? The disease is called functional constipation. So, functional constipation, as defined by our latest Rule 4 criteria, must include at least 2 or more of the following. So, first is straining during more than 1/4 or 25% of defecations. Second, lumpy or hard stools. Ito po yung Bristol stool form scale 1 to 2 in more than 25% of defecations. Number 3, sensation of incomplete evacuation in 25% of defecations. Number 4, sensation of anorectal obstruction or blockage more than 25%. So the key here is at least 25% of the time. Number 5 is manual maneuvers to remove the stool in 25%. No? Number 6, fewer than 3 spontaneous bowel movements per week. Number 7 is loose stools are rarely present. So, paano ka magiging functional constipation kung diarrhea pala yung predominant symptom? So, you should not consider those with diarrhea or loose stools to be having functional constipation. And number 8, insufficient criteria for irritable bowel syndrome. Bakit po dapat hindi siya IBS? Functional constipation may overlap IBS, but IBS is a totally different disease. IBS po ang classic symptoms po. So IBS is divided into 3, IBS-C, IBS-D, and IBS-M. So yung IBS-C po is irritable bowel syndrome, constipation predominant. IBS-D is diarrhea predominant. And IBS-M is mixed. Ano po ang key features ng IBS? IBS is abdominal pain relieved with defecation. So yun po yung pang-differentiate between functional constipation and IBS. Iba rin po ang IBD. Okay po? So look at the presence of the symptoms. So there is an asterisk po na dapat para ma-consider mo that this patient has functional constipation, the criteria should be fulfilled in the last 3 months. No? The patient should have these symptoms for the last 3 months and has been complaining of this for the past 6 months before diagnosis. Okay po? So this is what we call functional constipation. So when you put in your diagnosis for PhilHealth purposes, you should put functional constipation if you think the constipation is actually functional. Again, I would just like to remind everyone, constipation is a symptom. Functional constipation is a diagnosis. Okay, I hope that's clear. Now, we use the Bristol stool chart classification po. Sorry po for the picture. I hope none of you are eating dinner yet, but not just in case makikisabi po na po. So, number 1 and number 2 po, these are the ones considered as constipation symptoms. So in number 1 po, they are hard, separate, pellet-like lumps that are difficult to pass, hindi mailabas. Kaya po, goat stool-like. Ito po yung itsura ng parang tayo ng kambing. Number 2 naman is the lumpy sausage-shaped stool. So ito po, parang pinagdikit-dikit na goat stools. Kaya po yung Bristol 1 and 2 are considered constipation symptoms or yung constipation stools. Now, number 3 and number 4 po, ito po yung normal. And on the other extreme, the 5, 6, and 7, ito na po yung nakikita natin with diarrhea. Okay. So, there are certain health-related conditions that can be presenting with chronic constipation. Ito po yung sinabi ko sa inyo. Irritable bowel syndrome can present as chronic constipation because there is such a thing as IBS-C or constipation predominant irritable bowel syndrome. Remember po, dun sa Rome 4 criteria, you did not see abdominal pain in any of the conditions. It's always about defecation. So, ang chronic constipation po, although some of them may present with pain, it's not part of the diagnostic criteria to diagnose patients with chronic constipation. Second po, there are certain disease condition and metabolic disorders that you can present as chronic constipation or a side effect of the disease like diabetes, hypothyroidism, hypocalcemia, hypercalcemia, hypomagnesemia, and even uremia patients. There are also certain neurologic conditions po that can be complicated by chronic constipation. Remember, I'm using the word chronic constipation and not functional constipation because the constipation is attributed to the underlying disease conditions that are now being discussed. For example, when you have multiple sclerosis or Parkinson's disease, you can present one of your symptoms could be chronic constipation. ALS po, or the Lou Gehrig's disease, cerebrovascular stroke patients, because they are immobilized, they can present with chronic constipation. And those with spinal cord injury, no, because of their neurogenic colon. So hindi po gumagalaw because less of neurologic stimulation. And there are also certain mental health conditions that can be presenting with chronic constipation. So you have to be careful when you interview your patients, no? So anxiety, patients with depression, and those with anorexia nervosa, because they tend to try to prevent oral intake in those anorexia patients. Those with cardiovascular events, so you can see chronic constipation in 11% of patients, especially those with higher risk for heart disease condition, and even 19% for those who have had ischemic stroke. Okay. So there are also other related conditions to chronic constipation. These are possibly related to the bad bowel habits. Later on, hopefully, I could teach you po on how to teach your patients to improve the chance without medications. But definitely po, if they do not respond, we can use medications like elobixibad, no, or goofies. Now, there are also those patients who have low fiber intake and low liquid diet. That's why they have constipation. Those with sedentary lifestyle, especially patients who are on prolonged bed rest. Certain medications can secondarily cause chronic constipation like narcotics, especially these cannabinoids, anti-epileptics, and even morphine and its derivative can cause constipation. Those with laxative abuse, so hindi na po sila gumagana kasi inom ng laxative, that's why they present with constipation. And patients with pregnancy, because of the increasing size of the baby compressing on the colon, and especially the rectum, and worst of all, colonic malignancy can present with chronic constipation. Okay. So there was a survey done in 24,090 patients done in the US po. So the most severe symptoms of chronic constipation is actually having hard stool and straining. And look at the most bothersome symptoms po: bloating, straining, and hard stool. And the most prevalent symptom is actually straining. Look at the effect on the quality of life. Half of the patients interviewed have a decreased quality of life. And even 12% of them have affectations in their work and school. And even absenteeism po may effect po ang chronic constipation. But these are American patients. And unfortunately, we don't have any local data to say otherwise. But I would believe that there is correlation with chronic constipation and all this. It most likely is possibly meron din po silang kanya. Okay, I'll give you a case po. This is actually a case of one of my colleagues po sa gastroenterology. So He had a patient, a 68-year-old male, diagnosed with CKD. Remember po, uremia, 10% constipation. On maintenance HD na po siya, admitted due to abdominal enlargement. He has been on multiple medicines as maintenance and has been taking lactulose twice a day, quite a high dose. On admission, he has no bowel movement for a week. Oh, almost constipation po, no? And does not complain of abdominal pain with physical examination findings or globular abdomen and hypoactive bowel sounds. So ito po, during the presentation, he was also suspected to have acute coronary syndrome. So this patient should not strain because we don't want to strain the heart. So on admission, scout film of the abdomen showed kidney disease, bean-shaped colon, suggestive of volvulus. Oh wow! So this volvulus po is the acute bend or acute twisting of the bowels causing obstruction. An emergency CT scan was done which showed the same findings, but there were no signs of inflammation like edema or standing. So physical examination of the abdomen remains soft and untender. But in this case po, I just have to warn you po that ang caveat po of this case, because volvulus is a possible surgical emergency. Ang critical po dito, despite the findings of volvulus in the CT scan, there was no signs of inflammation. And looking back at the PE of the patient does not have signs of obstruction. That's why this patient was treated medically. Look at this. My colleague gave this patient laxatives at the start, and then ang ginawa po niya, so he was managed as a severe case of constipation. He was then given enema at the start to induce bowel movement, and then was started on elobixibat 10 milligrams daily before bedtime. After 2 days, the patient already started to have SBM po, or what we call spontaneous bowel movement. So the outcome, the patient enjoyed the benefit of elobixibat with increased frequency of defecation and easier to pass stools. Remember, this patient has already been taking lactulose BID, and because he was considered to have acute coronary syndrome, spontaneous defecations is critical because we don't want to induce another cardiac event. So issues with the case, this is an elderly patient, he lacks mobility, and of course, being an elderly, sometimes it affects the ability of this patient to increase fluid intake. Remember, patients with CKD cannot be hydrated so much. Mag-fluid overload po siya. Itong patient na to is under chronic dialysis. Okay. How about second case? This one naman po is a 75-year-old man who suffered from ischemic stroke and was referred for constipation. He has been taking various laxatives but has not been compliant due to adverse events of palatability, bloating, and sometimes even pain. So he moves twice a week. Remember po, less than 3 times a week ang definition natin ng constipation. And is noted to be staining. So he continues to have felt of rectal residue and so parang feeling of incomplete evacuation. Okay? So his past history, he already underwent colonoscopy 5 years ago, which was normal. So there's no indication to proceed with colonoscopy because colonoscopy po in a normal findings, pwede po up to 10 years. But he's been diabetic. So he can have diabetic gastroparesis. No? And he's also taking calcium channel blockers, ACE inhibitors, statin, and anti-platelet drugs. So what did they do? My good friend did. They started on elobixibat and advised the patient to increase fluid intake and fiber intake. So after 2 weeks of intake, the patient was satisfied with the medicine, now having 4 bowel movements. So I guess this is 4 spontaneous bowel movements a week and does not exert much effort and has decided to continue the medication. So these are 2 actual patients that have responded to elobixibat. Kanina pa po ako nag-elobixibat. What is elobixibat or glucose? This is actually the first in-class ileal bile acid transporter inhibitor or IBAT inhibitor for the treatment of chronic idiopathic constipation. So elobixibat po is the first in its class as an IBAT inhibitor. So IBAT inhibitors or ileal bile acid transporter inhibitors block the ileal absorption of bile acids by first interrupting the enterohepatic circulation of bile, resulting in a fall of serum cholesterol. So there is a potential benefit into lowering cholesterol with IBAT inhibitors po. And increasing the delivery of bile acids into the colon, thereby increasing colonic bile acid and mucosal fluid secretion. So there is a secretory effect, and it enhances colonic motor activity, allowing changes in colonic physiology, and it is been proven to be effective in treating constipation. So, just a review po, what's the enterohepatic circulation of bile acids? Bile acids po is secreted from the liver and delivered into the duodenum up until the terminal ileum po. So, once they are delivered as bile acids, they are initially conjugated to taurine and glycine, and these conjugates enter the portal blood in the terminal ileum to return to the liver. So, para po siyang water fountain, no? We mostly recycle our bile acids. Some of those unconjugated bile acids and secondary bile acids also return to the hepatocyte for resecretion. Yung sinasabi ko po sa inyo, recycling. Efficient intestinal conservation of bile acid depends on active apical absorption in the terminal ileum and passive absorption throughout the GI tract or the intestinal tract. So, ito rin po ulit yung enterohepatic circulation. So, what IBAT does is it prevents the delivery of the bile acids back into the portal circulation, thereby increasing the amount of bile acid that goes to the colon. Okay? So how do bile acids modulate the colonic transit? Bakit ba po nagkakaroon ng effective defecation with the increased bile acids in the colon? So there are two mechanisms. One, secretory. So bile acids increase colonic secretion of water and electrolytes, allowing more fluid and electrolytes to go to the colon, pushing the stool forward. And it also acts as a prokinetic. So certain bile acids are prokinetic in the colon, simulating higher amplitude propagated contractions. The most common side effects of bile acids are lower abdominal cramping and pain in 45% of participants. So haven't you noticed po that patients who have recently underwent cholecystectomy, di po ba dahil tinanggal mo na yung gallbladder, natatanggalan po sila ng storage ng bile acids. So these patients usually, these post-cholecystectomy patients would complain of diarrhea in the first few weeks of their cholecystectomy. This is the reason, because there is increased bile acid delivery into the colon. Wala na po kasi nag-co-contain ng bile acids na gallbladder. So, this is why. And bakit, Doc, nawawala yung diarrhea later on? Bakit nag-normalize ulit? Because of the feedback mechanism. Pag na-realize po ni brain that there's so much bile acids, the brain will start increasing absorption, thereby allowing less release of bile acids into the system. Okay? So, yun po yung actual mechanism of post-cholecystectomy patients. Okay. So, there was a systematic review done in meta-analysis of patients treated with chronic patients with having chronic idiopathic constipation in Japan. So, this is a meta-analysis and systematic review of the various medications that are being used in Japan. Okay. So, there were 4 medications in that meta-analysis. One is elobixibat, the other one is linaclotide, the other one is lubiprostone, and the last is lactulose. And the 5th arm is placebo. If you look at this bar graph, you would see that after intake of elobixibat, ito po yung first, towards the left, this one. Okay? You would notice that after the first week, significant po yung spontaneous bowel movements on the 2nd, 3rd, and even 5th week of treatment, showing that there is significant improvement in the constipation complaints of patients. Eh, Doc, bakit si lactulose po? Look at lactulose. It is fairly inconsistent coming on the 4th week, but there may be some effect after 5 weeks. But your patients will always complain that your medication is not effective. Why not use lubiprostone and linaclotide? These are not available in our country. So, about this meta-analysis look at how effective elobixibat or Gufis is in improving chronic idiopathic constipation. Look at this forest plot po. The forest plot of ilibiximab has significantly been proven in this meta-analysis to be effective in the treatment of chronic idiopathic constipation. How about lactulose? It touches 0 po. That's why lactulose did not show a significant difference compared to placebo. So at most po, lactulose tend to show benefit. However, ilubiximab is proven to be effective based on this meta-analysis. Okay, how about the safety and efficacy of chronic constipation? So this now is a phase 3 trial po. So there were 133 patients aged 20 to 80 in Japan, given for at least 6 months up to 52 weeks. Ang ginamit lang pong criteria dito for functional constipation is Rome 3. However, Rome 3 and Rome 4 definition of functional constipation po is the same. Okay po? Remember po, look here. There is less than 3 spontaneous bowel movement per week. Okay? So, look at this bar graph again. After week 1 po, a significant number of patients using the ilibiximab had spontaneous bowel movements. Ano pong ibig sabihin nun? Hindi gumana po after week 1 pa lang. No? And on week 2, that same effect is retained. How about CSBM? So this is the second graph po. CSBM means complete spontaneous bowel movement. Kasi di po ba, pinsan pag dumami yung patients natin, hindi po kompleto, may round 2, may round 3 pa. How about the complete bowel movement, spontaneous? So at week 1, there's again significant improvement in the constipation symptom, which is retained on week 2. Okay. How about safety po? So you can see from here, compared to placebo, ilubiximab is effective in the treatment of chronic idiopathic constipation. How about its safety? Okay. So as you can see po, the effect is retained, no? After 2 weeks, kitang-kita niyo po that up to 52 weeks, the effect on spontaneous bowel movements and complete spontaneous bowel movements have been retained. And in this study, it has been found to be safe kasi po, it was completed for 52 weeks, so more than a year of treatment. Okay, how about the effect of ilubiximab in the quality of life? And of course, satisfaction, because you need to make the patient satisfied in order to continue treatment. On the baseline po, look at the amount of patients not happy with their condition. And as the medication progressed, the weeks that followed, look at the number of dissatisfied patients. It is significantly reduced. The red bar po has significantly decreased on week 52. Those who are partially or slightly satisfied also decreased. And those who are fairly satisfied and satisfied has increased. So it is retained in the week 52 po. Ang galing ng medication. Okay. How about the drug side effects? Just as I told you po, the most common side effect is abdominal pain. Usually po, hypogastric pain and bloating. So, but if you look at this table, it is not as problematic as the others. Wala pong cardiac problem dito. It did not increase dissatisfaction in these patients. So, in that study po, phase 3 trial, 52 weeks use of ilubiximab 10 milligrams has been proven effective and safe. Okay. I'm almost winding down na po. So how about the effect of fruit intake on functional constipation? There was a systematic review and meta-analysis of randomized and crossover studies. So what did they find out? So there were 11 studies, and it was actually a kiwi fruits that are actually helping significantly improve stool frequency. So seen in 4 studies compared to, say, palm date and orange juice in the fixed effect meta-analysis. There were 3 high-quality studies suggesting that kiwi fruits have a better effect than ficus carica paste on the symptom of functional constipation as assessed to the Bristol Stool Scale. And there were 5 studies that show that fruits can increase the amount of Lactobacillus acidophilus, which is one of our beneficial probiotic and or probiotic bacteria. And the type of fruits include palm fruit, citrus fruit, and berries have increased the effect of bifidobacterium, another good bacteria. Okay? So kiwi fruits pala po sa mga prutas ang pwedeng makatulong sa functional constipation. Okay, how about the art of defecation? This is what I was telling you po, to improve yung non-medical treatment for your defecation. So this one, because our muscle, our puborectalis muscle, pag level 90 degrees po ang sitting up ng pasyente natin, the puborectalis muscle is actually partially contracted. When you elevate to 35 degrees, that allows complete relaxation of your puborectalis, improving the possibility of spontaneous defecation. In summary, constipation is not an uncommon problem in adults and results in frequent consultations, anxiety, discomfort, and even poor quality of life. Bile acid increases colonic secretion of water and electrolytes, and certain bile acids are prokinetic in the colon, stimulating high-amplitude propagated colonic contractions. Ilubixabat is a locally acting IBAT inhibitor that leads to increased bile acid delivery to the colon and represents a new class of treatment for chronic constipation. Ilubixabat is well-tolerated, improves quality of life, irrespective of potentially confounding patient characteristics. So collect toilet defecation and toilet habits, in addition to regular exercise and increased dietary fiber, and liquid intake are still irreplaceable in maintaining regular bowel movements. With that po, I would like to thank everyone for listening.
Thank you very much, Dr. Ruther. It has been a very, very informative lecture, no? Yung mga akala natin na, ano lang naman yan, simple lang naman, constipation yan. But for most of us here, we are reminded that when we are doing our medical certificate, so we have to remember the diagnosis should be, it's either functional constipation or chronic constipation. Di ba, Dr. Ruther, kasi ngayon marami na tayo mga natatanggap na may mga fake medical certificates na questionable talaga yung diagnosis. So you would know talaga if this is a real physician or not. That's one takeaway.
Thank you, Dr. Ursel. I agree with you.
Okay. So the next is actually medyo na-amaze din ako with regards dun sa the art of defecation. It's actually quite common, Dr. Ruther, in the workplace. As you know, most of our participants here are occupational health physicians from the Philippine College of Occupational Medicine. So this condition, actually, I'm talking about constipation, is something that is common but is rarely talked about in the workplace. One reason is that sometimes they feel it's quite sensitive, no? Medyo nahihiya sila. But for me, siguro after this talk that you had, I think we should also include this in one of our awareness program in the workplace so that they would feel more comfortable talking about it. Given that, di ba, yung minsan kaya nagpo-consult sa atin yung mga patient natin, lalo na if it's regards with constipation, it's because of the discomfort na very discomforting na sa kanila. Ilan-ilan lang yung talagang worried sila na, ay, bakit biglang nag-iba yung bowel movement ko? That's very rare. So anyway, we have some questions here. I have a phone-in question, but I will start with the question on the chat box. One of our participants is asking, is Elobixabat still effective for elderly that are post-cholecystectomy already?
Yes po. Yes, Dr. Ram. Because as I explained to you, eventually the body responds to the post-cholecystectomy situation. So what we try to do now with IBAT inhibitor is it actually prevents that bile acid absorption. So there will now begin an increased delivery of the bile acids with IBAT inhibitors po. So yes, they are effective in patients who are elderly and post-cholecystectomy patients.
Okay, thank you for that answer, Dr. Luther. Now, my phone-in question is actually a follow-up of this question. The question is, of course, we're talking about elubixibat. In your practice, sir, do you recommend using elubixibat as our first line of management for dysfunctional constipation and that of the chronic constipation? And follow-up to that also, can it be used in kasabay ng mga laxatives natin? Or should it be isa-isa lang muna and then we don't do combinations at all?
Okay. The first question po is it one of the first line? Yes po ang sagot doon. But there is a precaution po that you have to make sure that your patients do not have alarm symptoms. So for example po, these are patients more than 50 years old. So syempre po, I hope you understand you have to screen for colon cancer muna. Make sure that these patients are not taking other laxatives po. Because if you're taking other laxatives, if you add another laxative, what will happen? You will have drug-induced diarrhea. So, ang suggestion po natin is to choose one and then try first before. By the way po, let me teach you how to use elubixibat. Elubixibat is given before breakfast. It is best given as 10 milligram once daily. But you can taper it po depending on the side effects of your patient. So for some patients who develop abdominal pain or cramping, you can actually decrease elubixibat to 5 milligrams. So once daily lang po. Now, kung wari naman po, hindi pa kayo masaya dun sa 10 milligrams, you can increase up to maximum of 15 milligrams once daily. So yun po yung adjustment sa kanya. But you do it after 1 week of treatment. Parang weekly po yung adjustment para you allow the medication first and see how it would be as effective as you would like or as the patient would like. Did I answer your question,
Yes,
Dr.
actually,
nakalimutan ba ako?
you answered the next question already, Dr. Luther. Pero meron pa akong isang question. So how about the duration? How safe could we use it? For how long? Can we use it for a year?
Thank you po. Thank you po. So, because elubixibat is relatively a new medication, the study, this phase 3 study is actually one of the longest studies in terms of safety and efficacy po. So, as you can see, it's safe up to 52 weeks. I'm not sure how to extrapolate data po, and I don't think it is safe to extrapolate data beyond 1 year. Maybe later on, ISI will be able to give us additional studies on the safety of elubixibat beyond 52 weeks. Now, ang tanong po, do you constantly treat these patients? If they are functional constipation, yes, you can continue po. But of course, you have to discuss this with your patient because you have to make them understand that this medication will improve your spontaneous and your complete spontaneous bowel movement po. Parang in partnership with decision making, hindi mo sasabihin sa, 1 year ka nang iinom ha. Tingnan natin. Ano pa?
Sa case-to-case basis din naman, di ba, Doc?
Apa.
So with that, I think that's the last question that I have on my inbox. So I would like to thank you, Doc, for a very enlightening and comprehensive lecture. It's, of course, an honor for us to be able to have you as one of the speakers. No, this is something that we really don't talk about, pero it's a good thing that we were able to discuss this tonight because magagamit talaga namin sa practice namin, especially in our clinics. No? So with that, thank you very much again, Dr. Luther.
Thank you po.
Good evening.